Good afternoon. That's me. I'm Paul. I'm a community cardiac specialist nurse, and I'm a team leader for a heart failure team in North Sefton. Now, I'm going to talk to you about the role of the community heart failure team, but I'm going to look at it a little bit from our perspective, because I think anybody in the room who's a community heart failure nurse will know that these services differ in their provision, in their staffing levels, in their support, and they're often tailored to what their local needs are. So whilst some of the stuff may be relevant to your service and some of it may not, so just bear that in mind. I'll try and be as broad as I can around what we do. So this is our morning safety huddle in the community. As you know, anyone who works in heart failure, you know that can't possibly be true, because look how many nurses are on that picture. You could divide that by 2 and take 1 away, you're about right for how the services are funded. But the community heart failure service aims are based around a lot of the things that our colleagues have spoken about this morning, which is around getting the patients identified with heart failure and referred into the community services, at which point we look to optimise all the evidence-based medication, both for newly diagnosed patients and for managing those that are decompensating and coming back into the community service, where we look then and revise therapies, because again, as has been talked about this morning, therapies have changed a lot. Certainly, I've been doing heart failure for about 9 years, and the treatments today are very different from the treatments 9 years ago. And the way that we access services have changed as well. One of the priorities for community services, again, harking back to the slide you've seen a few times earlier today, is about minimising hospital admissions for heart failure patients. We know that they don't do well. They often are in hospital for a long period of time. So reducing hospital admissions for decompensating patients is key. And that ties in with the optimisation of medical therapies. One of the larger parts of community care, which I think is quite unique to community services, is the management of palliative and end of life. Again, it was mentioned earlier on, I think, in Dr. Din's talk about the mortality rates for heart failure and the way that we discuss this with patients. You know, it's 50% mortality at 5 years is significant. And I think we need to be honest with patients about that, because they want you to be. We work in our community service very closely with the palliative care and with the hospice, and they provide a great service in terms of managing long-term conditions. This isn't a service that's necessarily replicated around the region, but we know that from our local palliative care, we have an excellent service, and we'll talk a little bit more about that in a moment. One of the other roles, perhaps the more difficult, complicated, time-consuming aspect of our job, is the integrating of primary care, secondary care, tertiary care, and all the allied community services, because heart failure patients don't just have heart failure. They have a great many comorbidities. And they're not just being managed by us, they're being managed by colleagues in the secondary care and in tertiary care, by consultants, by specialists in palliative care. And actually, when you look at that, and I'll allude to it in a couple of slides' time, the person that's often sat in the middle of that, that's pulling all those strings and orchestrating everything for the patient, is the community heart failure nurse. They are the anchor. And I think one key thing that's maybe changed in my time in heart failure is that community heart failure nursing now is not about routine monitoring of heart failure patients. Again, as was mentioned earlier on, the volume of patients coming into heart failure, the new referrals, the new diagnosis, is really high, and it's only going to get higher. So the idea of optimization and stabilizing patients then allows us to refer these patients back into community primary care, which means we can then focus on the next acute decompensating patient. So that's a rough guide to what we do. So in our team, we have a mixture of staff. We have a group of Band 7 advanced practitioners. We have Band 6 trainee nurses, and we also have a HCA. And I think, again, my colleagues in secondary care and tertiary care, and for my colleagues in community care, where's the next generation of heart failure nurses coming from? There isn't a robust pathway in there. In our service, we try. Well, I battle very hard with our managers to allow us to provide Band 6 roles to develop staff, because these opportunities are few and far between, and the services need to grow. And the problem with growing services is that you do need staff to staff them. We have a mixed delivery to our care, so we provide it domiciliary in the patient's home. There are obviously those patients that aren't able to get to hospital, that aren't able to get to community clinics. We have a series of community clinics. My footprint is from around, those of you that know Sefton, is from kind of Hightown all the way up to Banks, which is quite a large area, and we try to deliver clinics in each of those small boroughs every day of the week, which obviously is better, and we're aiming to bring care to patients rather than patients constantly having to come to us. That's more efficient for the patients, and it's less stressful. What we also do is we have MDT support. So my service is nurse-led, as a lot of community services are. So we are relying on highly advanced skills from the nurse practitioners and from the staff, and passing that knowledge and skills on, but we do require the consultant input. Obviously, patients are complex and treatments are changing. And I think as we saw at the discussion at the end of the last session, this is really paramount when it comes to the development of new treatments, and the conflict between what's able to be delivered in tertiary and secondary care under the consultant vision versus what we're able to do in the current pathways and guidelines. Because as a nurse-led service, you are beholden to what the practice guidelines are in terms of prescribing. And we'll talk a bit about that again in a slide or two. And again, we have MDTs. As I say, our palliative care support is excellent, and we support that with a monthly get-together with a cardiologist and the consultant from palliative care and some of the palliative care nurses. And we have a huge cohort of co-managed patients. And this is not just around end of life, this is mostly around patients who've reached their ceiling of medical intervention, and how do we manage those acutely breathless patients at home that are not suitable for devices, that are not suitable for any more medication, but still expect quite rightly to have some quality of life, and how do we support that? So working together with our colleagues, we're able to give better outcomes. And as I say, we're in the community. We're one part of a large raft of services, and we need to be able to integrate with them. As I say, patients with heart failure may have respiratory, diabetes, renal failure. There are a whole raft of community specialist nurses, and we all need to be on the same hymn sheet and be able to speak freely with one another and swap our ideas and co-manage patients. If someone's being managed by a matron, do they need a heart failure nurse to be going to see them as well? Do they need a diabetic nurse to be going to see them as well? Can that be managed more efficiently, one visit that does it all? So constantly thinking about these things for every patient is what our responsibility is. So the key relationships, it's a busy slide, and this is what it's like every day for every community heart failure nurse. So we have our obvious relationships with the GPs, where the new diagnosis and the decompensating heart failure patients, they refer them into the service for us to initiate and up-titrate medications to manage decompensations. But equally, when we reach the end of our input with that patient, we need to be able to pass that patient back to the GP for them to continue to monitor their symptoms and look for any decompensation down the line that might refer back to us. Secondary care, patients, again, one of our main routes for referrals, patients presenting to A&E with, as we say, breathlessness, ankle edema, orthopnea, PND, these kind of things that often present in the middle of the night and they result in an ambulance phone call. Having robust pathways, having good relationships with your secondary care centre means that you can facilitate admission but also discharge. And where possible, if there's heart failure services within that secondary care centre, then you want to have robust input with them. A good example of that is with our colleagues at Aintree, where they do offer the ambulatory services, and our service are able to access that for our patients when necessary. We don't have a community IV. We don't have a community IV service, one that delivers at home, and there isn't one in our local secondary care centre, but Rajiv and the team in Aintree are very happy to take our referrals and review those patients, which is excellent. And the tertiary care centres, colleagues Matt and Archie, and Jay, we rely on them for our advanced therapies. Patients do reach a point where we get them optimised on their therapies, but we obviously device therapies, they need to be in secondary care. They may need further investigations, valvular patients. We have to be able to have that two-way relationship. And likewise, when patients are reviewed and seen in tertiary care, we often get a very detailed plan of what they would like us to do in the community, and this is excellent. As a nurse-led service, we thrive on that kind of thing. It really helps us to deliver our care. And again, palliative care services, as I say, this is perhaps our most groundbreaking area in Southport, because the population of Southport is predominantly elderly. Okay, and the last few years, we have managed to achieve great things in terms of allowing patients with heart failure to die in their preferred place of care, being managed at home with family, not in a side ward in A&E at 3 o'clock in the morning, but managing expectations, getting care in place, working with our district nursing colleagues, working with our palliative care colleagues, working with the respiratory team. We're able to allow patients to to reach the end of their journey in the place of their choice, which has a huge impact on not only them but their family and those that are left behind. And I think one of the innovations in our Southport area that we've had in the last 3 or 4 years has been the development of a community cardiology hub. Now I know in Knowsley they've got the sort of one-stop shop. We aren't quite there yet with our service, but in order to support the secondary care centre, there is a community cardiology hub which is staffed by a consultant cardiologist and a physiologist, where patients are able to get rapid access to investigations, not just for heart failure, but for all cardiological conditions. And then I think it goes without saying that we have a weekly MDT with a consultant cardiologist to support our practice. There are many, many complex patients in the community, and when we're trying to avoid admissions, we want to make sure that patients receive the best quality of care, the most evidence-based care that we can. And we can't do that without the support of a consultant cardiologist. And Dr. Hammond provides an excellent service for our team and for the team in West Lancs. And so that's a rough idea. I think it's probably worth mentioning one other thing on here which I mentioned, which is the community paramedic service. I don't know how many people have got access to a community paramedic. It's a relatively new thing. But we have a specialist paramedic who often contacts us while they're out on 999 calls with a patient who may be known to the service. And rather than scooping them up and running into the department, they'll ring one of us and say, "Are you aware of this gentleman? We've seen them today. They're presenting with decompensating symptoms. We think we might be able to manage it at home. Would you be able to do a rapid review in a day or so? Could you give us some advice on what you want us to do? We'll get it to the GP." Which is excellent, and we do use that. Our community paramedic is quite a character, and he's very into heart failure. He's very into integrated working. And along with that, we have access to something called the ERIS system, which is an online care plan for paramedics to access. So again, going towards our palliative care aspect, patients who are not for hospital admission, patients who we've sat down and written an advanced care plan for, when the paramedics turn up, they're able to access a care plan on the ERIS system, which might say the patient's not able to say that themselves. This patient does not want to be admitted to hospital under any circumstances. This patient wants to be treated at home. They have access. They've got anticipatory drugs in the house, they've got a DNAR, and this again helps the whole service flow, helps the patient journey, helps the paramedics in optimising their time, and helps us to make sure that patients, we know they're getting the right treatment even when we're not there. And so how does this document support us? Well, I think one of the key relationships we have is with GPs, and helping them to find these cases and bring them forward is a great thing. I think we know that some of our colleagues have been doing case finding in the GP practices for a while, and it does help to bring stuff to the front. The document it supports teams like mine who are nurse-led, I think, as we just alluded to before, which is the medications issue. We need all this information in one place to give to the commissioners to go, look, this is what a heart failure service looks like. This is what it looks like in hospital. This is what it looks like in the community. Instead of sending 10 different documents with various recommendations, we've got it in one place to go, this is the service. You now need to design a heart failure team to fit around that. And for the future, really we just continue what we're doing, try to deliver as much of our care as we can closer to home. I think we need to be looking at moving things that were traditionally secondary care out into the community. We have skilled nurses, we have skilled GPs, we have consultants with an interest in community care. We don't need to go to hospital for echoes, we don't need to go to hospital for ECGs, we don't need to go to hospital for 24-hour tapes. We don't necessarily need to go to hospital for a consultant review, so why are we dragging patients 20 miles out of their way for a 5-minute appointment? We need to look at how we can deliver these things closer to home. I think really that's all I have to say. Thank you very much.